Hello, everyone, and welcome to the Veterinary Business Podcast, your ultimate resource for developing a successful veterinary practice career. I'm Dr. Peter Weinstein, one of the co-hosts of the Veterinary Business Podcast. On this podcast, we bring you insights and expertise from industry-leading doctors, experts, and thought leaders. We cover a wide range of topics, including practice management, marketing strategies, leadership development, HR best practices, and much, much more. So whether you're a practicing veterinarian, a practice owner, a practice manager, a veterinary student, or just somebody interested in the veterinary profession, this podcast is tailored to help you navigate the unique challenges and opportunities in the business of veterinary medicine. Every listener of this podcast is welcome to visit www.veterinarybusinessinstitute.com for additional resources and tools to support your growth. And remember, you can subscribe to our podcast on iTunes, Google Play, Spotify, and any of those popular podcast platforms that are out there. Let's get going. I'm excited to be talking to Dr. Fred Wininger, veterinary neurologist, adjunct professor at the University of Missouri at Columbia, go Tigers, owner of 3D Veterinary Printing, and also, applause, winner of the Bridge Club Bright Minds 2023 Game Changer Award. And today, we're going to talk about changing the paradigm for veterinary specialists. Did I get your last name right, Fred?
Close enough. Wininger. You got it.
Wininger. All right. So before we get started into all of the game-changing, mind-altering thoughts that you have, let's learn a little bit more about Dr. Fred. First of all, did you grow up in a veterinary family, or when did you decide that you wanted to become a veterinarian, like reading James Herriot or something?
Yeah, I'm excited to share all that. And Peter, this is the closest I'm going to get to say long-time listener, first-time caller. So I'm going to throw that out there. I think like most of the veterinary listeners in the audience, I just felt like I knew something a little bit more about animals than my friends and the people around me. My parents would find me with the World Book, not the Encyclopedia Britannica book. I'm old enough that we had World Books, with volume C and D, because cats and dogs were always being investigated. And so, yeah, I didn't grow up in a veterinary family, but I did love the idea of the challenge of veterinary medicine, taking care of those things that couldn't speak for themselves. And I wasn't a particularly good student. I struggled. In fact, the recruiting officer at the University of Pennsylvania he said, "Can I take you out to dinner at the end of my first year?" And I said, "Sure." I didn't know what the conversation was going to be about. And he said, every year we know where our students are going to land in their class ranking within about 95% confidence. And we had planned for you to be at the bottom of the class, and that didn't happen. So what's different about you? And I think just what I share with a lot of our audience is just a lot of passion for animals.
Wow. It's nice to know that there are other people besides me that were not a good student. I mean, I think many of us who are in the veterinary field, we had a passion for animals, we had a passion for medicine or science, and we brought the two of them together. And then, at least in my situation, as a undergrad, I think I got distracted by all sorts of interesting things like fraternity houses and parties and so somehow I got into veterinary school, and I don't know about you, but I thought veterinary school was easier than undergrad because I just had the desire to graduate, and it became more fun than the hyper competitiveness of just getting into vet school. Once you're in, as I like to say, C equals DVM, right?
Yeah, 100%. I mean, when passion becomes purpose, right? And so it's not about getting through classes because you want to get to that beer. And at the end of the day, I mean, it was because you actually enjoyed being there. And I had the luxury of being out for a year before I went to school. And I think a little space between undergrad and veterinary school gives you a little bit more perspective on what you're doing there. So absolutely.
Yeah, I had a
Absolutely.
gap too, but it wasn't by choice. The fact that everybody rejected me the first couple of times around. But it all works out because you became a boarded neurologist. You're a diplomat of the American College of Veterinary Internal Medicine. Was that something that while you were in your vet school curriculum, you decided, well, I'm not going to do equine theriogenology. I'm going to do small animal internal medicine?
I was actually inspired before I went to veterinary school. In that year between undergrad and veterinary school, I graduated without any idea of what I was going to do with my life. I was power washing my parents' deck and they were giving me $20 and they said, "Can you please get out of the house?" So I opened up the Yellow Pages. Yes, there was Yellow Pages at the time, and I had worked in veterinary hospitals as just kind of a kennel attendant most of my life, and I just happened to open up the page to this hospital. It's called Red Bank Veterinary Hospital. I didn't think much of it. And all of a sudden, I'm in one of the biggest referral clinics in the country. And I remember working with a doctor. His name is Rick Glass. He's a pretty well-known neurologist. And just watching this guy walk around, I was like, he's doing some cool stuff. I mean, he's waving his hands at these dogs' face and flipping their feet over. And he says, "I know what's wrong with your dog." And so that's one of the things I always loved about neurology. I think most people in my specialty would say the same. If you're into veterinary medicine because the detective work of it, because you ask animals questions and they give you answers, it is the sexiest part of veterinary medicine because the examination tells you something that nothing else can. I mean, we have fancy things like MRIs and electrical testing, but none of that is going to tell you if the proprioceptive methods are working or if the dog can see. And so I was very attracted to veterinary neurology when I realized that the examination was the coolest part. I dabbled with other things like ophthalmology or whatnot, but there's also that life or death component to neurology. I mean, you're not going to nucleate the brain very often. So I just loved the intensity of it. And I loved the fact that the detective work that made me interested in veterinary medicine in the first place is ever present in neurology.
Yeah, I always thought of veterinary medicine almost like a Sherlock Holmes novel. He didn't have the technology that we have now in terms of doing. He had a magnifying glass, or
Yeah.
whatever he had. So a lot of it in veterinary medicine is using as many senses as you're comfortable using. The sense of taste, at least in this generation, we don't have to, but you probably can go back an entire couple of generations to tasting urine to look for sugar. Um,
Hey, I still smell dogs' ears all the time when I'm
right.
worried about their vestibular presentation. So absolutely. I remember my father saying to me, you're getting into neurology because you like the neurologic examination, the localization so much, figuring out anatomically where they have a problem. But whole body MRIs aren't far off. You're going to become obsolete. And I was just reminding him that structure and function are two completely independent things. And it's really cool that there's no other way of assessing function than getting on the floor with a dog. I think it's awesome.
It's interesting. I'm very good friends with Steve Ettinger, and we get together a couple of times a month and have coffee. And after 9 editions of Textbook of Small Animal Internal Medicine, the so-called Bible for internal medicines, the one of the first 3 or 4 chapters in all 9 editions is the physical examination. And we can't forget how important the physical examination is before you go to the MRI. And I think some of technology has allowed us to bypass what is the foundational tool that we have, which is us and our brains and our assessment and taking a history and everything else. So I have to remind people that before you can get to the MRI, you have to do a hands-on tip of nose to tip of tail examination. Any comments?
100%. I mean, I had a family member recently that went to the ER the other day. They weren't feeling just pale and cyanotic, and they didn't touch him. The first thing that they did was whipped him through the CT and got some blood work. And I was just really struck by that. And I think that yes, the pillar of what we do is history and physical examination. In the absence of it, how could you ever come up with an appropriate differentialist, especially in light of the fact that I do MRIs all the time, and I find abnormalities that have nothing to do with the presenting complaint. So it's so important to know why we're doing what we're doing before we start looking for it.
Yeah, and to those veterinarians who are listening, in my role, one of my prior roles as an executive director of an association, one of the more common complaints from consumers regarding the veterinarian to whom they went was they never touched my pet. Now, they
Yeah.
probably did, but unless they see it, feel it themselves, that perception does lead to state board complaints.
I was going to say 100%. Clients don't see you if they like you, and they like you if they know you care. And it can almost become a self-fulfilling prophecy, regardless of the outcome of the patient. If they think that you are invested in their dog, they'll be happier with the outcome regardless. And I found, as a neurologist, taking the dog outside and doing a gait evaluation, even if I already know and have seen what the abnormality is going to be when they were walking in the door, just gives the clients that extra encouragement. Hey, I've been worried about that for a long time. Thank you for looking. It makes a huge difference.
And one final thing before we get into some more meat, not that we're not into meat at the moment. I didn't know you were a Jersey boy.
I am. I can fist bump with the best of them, and I've been down the shore. So I am a Jersey boy, East Brunswick, New Jersey.
Very cool. So a shout out to all the peeps from Jersey who are listening. And all right, so you're a specialist. You went through a lot of training to get to this point in time, and now we're kind of, I like to think we're at an inflection point in the veterinary profession, and there's a lot of things that are going on. I'm not sure what the future is going to hold. I keep pulling out the crystal ball, and all it says is the future is murky.
Hmm.
So let's talk about some of the veterinary related issues and how they may relate to you and to the profession. And again, the opinions of our guests are those of our guest. So is there a shortage of specialists?
Oh, you know what they say about opinions, Peter. Everyone's got one, right? So,
Yep.
um, is there a shortage of specialists? The job task analysis that was performed by American College of Veterinary Internal Medicine would say yes, particularly in underserved areas. Um, but I think it's an ever-moving question or quantity, especially in the post-COVID era. I think it really speaks to the population need to a certain degree, how many pets are out there. I think it speaks to the expectations of luxury care. Frankly, specialty care to a certain degree is luxury care. And is that the expectations of our clients? Do they have the financial means and interest to go to the what some would consider heroic measures that we would do in the human field? And I think another variable from a population need standpoint that really gets ignored is the type of pets that are being purchased. And uh, I work at a practice called Charlotte Animal Referral and Emergency, but I've been tempted to change the name to Charlotte French Bulldog Referral and Emergency. And I know this is I know it's a hot button issue, but we have a greater volume when we have a patient population that is going to be more predisposed to certain things. It's been seen in every specialty. A breed gets popular, and then whatever their medical predisposition gets really busy and then goes away. And so I think that the need for individual specialists can actually mirror the interests of the companion animal desires. And I think another variable that's not spoken about as much because it seems like a little bit murky to talk about are the expectations of the professionals themselves. If a neurologist wants to make a lot of money, they don't want a lot of competition. And so they're not going to create that competition. And likewise, if young graduates are coming out of out of school and they decide I can go into general practice and start making X dollars, or I can spend the next 4 years getting abused, making garbage, and then come out what's on the other side. I think those are going to be really big variables on if there's a shortage of specialists or if it's just specialists that don't want to work as much.
Yeah, I mean, with the current trends in the veterinary curriculum to seeing fewer students doing internships and even fewer than doing residencies, it's going to take almost a generation to start to move the ball in the opposite direction. And I can look back, and it's not that long ago that more than 50% of the students were doing post vet school education, and now it's down below 30%. So it takes a while to build new specialists. We have a number of new veterinary schools in the future coming up. We'll talk about that in a little bit, but the shortage of specialists could be an issue with respect to the quality of care that patients can get access to, because there's only one Dr. Fred able to provide care, and especially when you have a niche like you do. I mean, you're very focused in one situation. So could you see that this shortage of specialists might have unintended consequences on individuals like yourself when there's just not enough of you to go around?
Absolutely. I mean, that's a Pandora's box of questions, right? Why are we making less? Why are people pursuing advanced training after veterinary school less? Especially in light of the fact that the opportunities for that advanced training are greater. There's more internships and residencies across the board than there ever has been before. And another hot topic is the corporate sponsored residencies and internships that have all these obligatory commitments afterwards. Those are also present as well. So despite the fact that you have an increase in training opportunities, you have less interest in pursuing that training. And speaking to your crystal ball, why is that happening? Is it because people don't want to go through that level of advanced training? Is it because of the poor pay associated with advanced training? Is it because of the fear that they wouldn't make great specialists? It's a big question. But yes, the concern is if you have less and less specialists, then not only is the availability for that level of advanced care starting to deplete and diminish, but the investment in advancing that advanced care goes away as well. I mean, and we can talk perhaps later about academic institutions and how empty those halls are becoming. But we're here because of the shoulders of giants that came before us. And if we're not creating more giants, I worry that advancing veterinary medicine is really going to start becoming limited and copying our human medical counterparts.
I want to go back to one other thing you mentioned earlier. This is kind of a sidebar question, but you mentioned that you want to be the Charlotte French Bulldog specialty hospital. Do you think that we, as the generalists, spend enough time focusing on client education about breed selection, number one, and then once breeds are selected, about breed specific issues? In other words, shouldn't we as generalists help clients choose their pets, and then once chosen, help them understand what to expect?
Yeah, to be clear, I don't want to be Charlotte French Bulldog in emergency.
Oh,
I
I know.
have become it by design. Because veterinarians always say, well, it's job security. And I say, well, that's not the job security I want, because I'm looking for positive outcomes. And despite the fact that they may present more with similar problems, their outcomes are actually quite a bit poorer than some of their breed counterparts. It's a good question. What level of intervention should veterinarians have on the choice of breed and the expectations of breed? I think trying to help our clients make good choices with regard to breed selection is, I think it's frankly a lost cause. I hate to be a dark cloud on that, but people choose animals for a variety of reasons, and usually it's emotionally guided, not guided by coached logic. I do think it behooves us to kind of prepare them, but I think the most important thing along that is the promotion of pet insurance. When it comes to these breeds that have these predisposed conditions, we're not talking about inexpensive care. We're not talking about slow trickle care. We're talking about acute, emergent, expensive bills that clients are not prepared for. And it's literally life or death decisions that they're making. And so I think educating them early when those owners are bringing in their puppy exams, that's when we have to be hitting them with regard to insurance, because any client that has a French bulldog that comes to see me has somewhere in their record possible IVDD, and then it's a pre-existing condition, period. And so that $7,000, $8,000, $10,000 bill, if you live on the coasts, falls on them, and they say, man, I wish I'd gotten insurance. So I think it's a real opportunity. Unfortunately, as a side note, I think it is likely that being a French bulldog will eventually become a predisposition or a predisposing factor, because it's just the likelihood of these dogs developing diagnosable and treatable, if that's a word, diseases that are expensive is gonna make it cost limiting for the insurance company. So I do worry about that.
It's an interest. I mean, again, it's part of our dilemma going forward as French bulldogs have moved to the top of the list of AKC. I used to joke when I was in practice that Cocker Spaniels, we should be doing lateral ears when we neuter them, because that's coming on down the road as well. Go ahead.
I was just going to say something quick about the French bulldogs. I love French bulldogs. I get why people get them. It's not just their cuteness, it's their personality. I think that why the breed has the ire of the veterinary field, and why it is so separate from any other dog that has a breed predisposition that became popular, like cavies with mitral valve dysplasia, or Dalmatians with urate stone formation, or any other breed that gains popularity and had that similar increase in medical issues, is that there is not such a thing as a normal dog French bulldog. I cannot image a French bulldog that doesn't have some degree of a spinal malformation. It's just the normal is so abnormal that it makes them uniquely not suited for longevity.
Yeah. Well,
yeah.
I should probably just do an entire podcast on breed and breed related anomalies. And having worked in the pet health insurance industry for 2 years, I became very knowledgeable about genetic predispositions and congenital and hereditary. And let's just say that most of us in clinical practice were never educated on this in veterinary school. And so with the genome studies that we've got and the diagnostic testing that we've got, we almost have a responsibility to help clients, but many clients don't want to hear that. So it's an impulse purchase in many situations. Let's get back to being a boarded specialist a little bit and recognize that your job is threefold: diagnose, prescribe, and do surgery if that's part of what you do. But to be able to do everything you do and to see the number of people that you see, and especially since if your practice is similar to others, that number increased dramatically during the pandemic, you have to know how to use your team. And so it's kind of a two-part question. Number one, do you have any VTS on your team? And that's to promote the VTS concept. And number two, can you explain how you optimally use your credentialed technicians so that it allows you to do what you have to do and what you're passionate about doing, but also allows them to grow and contribute to your practice?
Yeah. I think if there's anything I'm most proud of, it's being part of my team. And despite the fact that I might be a leader, my technicians are independent, autonomous colleagues, if nothing else. And I've been told by veterinary technician specialists and people that coach in that sphere that specifically neurologists are a model for how veterinarians should be treating their technicians, because long ago we recognized that if we want to accomplish the things that we want to accomplish, we're going to have to lean into our team. In a typical day, I'm seeing appointments while my back of the house technicians are running anesthesia autonomously, operating MRIs autonomously, often making initial interpretive findings on the MRI, not because they're diagnosticians, but because they need to know where they're going to make next sequence decisions or next images decisions based on regions of interest. And they set up complex surgeries, draping them and getting them ready for us. And it's not just restricted to the manual technical capabilities of our technicians. Then towards the end of the day, I'm doing more procedural things. And my front of the house technicians are answering complicated questions about anticonvulsants, recognizing warning signs in patient care and drug interactions, and handling most of those things. Also, they're doing complex discharges of patients that presented paralyzed and are now having trouble walking. So my technicians do things that I don't know how to do. I think that there is this kind of idea that veterinarians know everything in the hospital, they know how to do everything in the hospital, and we are gifting or generously offering autonomy to those below us. That's not the case with us, at least. They have a skill set and a knowledge base outside of mine, and this misconception that we should know how to do everything is folly because they have a different job than I do. Why would it be the expectation that as a veterinarian I would be more technically able than a technician? It doesn't make sense. So rather than a hierarchical supremacy, I'm good with the idea that I'm part of a team. To your question about VTSs, I'm always trying to elevate my technicians, my licensed technicians, to reach the goals that they have. And for some of them, that's become specialized, and for some of them, it's not. I don't know that, despite the fact that I would love for all of them to become specialized veterinary technicians, I don't know that it's absolutely necessary for them to reach their goals or be an effective part of the team.
So to attain the levels in your practice, they need to be trained and they need to be trusted. So how do you take a piece of clay and mold it into what you're looking for? Do you have training programs within your practice? Do you have train the trainer type situations? In other words, how do you elevate your people so that you can be upfront and have them trusted in the back to do what you want from an outcome standpoint?
Yeah, from an operating procedure standpoint, I work at a very progressive practice that I'm proud to be a part of. We have a technician internship program where we kind of handpick a lot of our technicians after technician school. And then for technicians that don't go through that internship program, they do go through a rigorous initial training program with a designated trainer. And they also spend a lot of time in the ICU, ER to get that kind of general medicine experience. Beyond that, the choice of a technician, I think a lot of us are looking for investment. It's a lot of effort to train a technician, just like any other position. And you want to know that they're there so that you can reap the rewards of that investment that you're going to put in them. If I'm going to give you, I want something back to a certain degree. That is zero sum in that regard. But I think it's a lot like choosing a resident. You know, it doesn't take much more than enthusiasm. Enthusiasm goes so far. And self-starters, lifelong learners, why do we have these expectations of veterinarians and not our staff? That's my expectation of our staff. And I've been very fortunate that they are that way initially, and then the buy-in comes not from financial gain or something like that. It comes from the knowledge that they were as integral in making that dog walk again as I was, and that's the truth. Again, because I'm just a part of a team, and that sounds like hyperbole, but it is true. My technicians truly know how to do things in the hospital that I'm not even aware are happening.
I love this because as I'm a huge advocate of team-based healthcare delivery, and I think we don't do enough of it in especially the general practice setting. I want to acknowledge the fact that you just gave a great shout out to your team. One of the biggest issues in the profession at all levels, veterinarian all the way down, is retention. You know, you invest in your people, and then what can you do to keep them? So how, or are there things you do besides just giving them a shout out on a podcast? Are there other things you do to recognize the value of your tech's time and expertise and contributions that makes them want to stay and play rather than leave?
Yeah. And I think that I think that's especially hard for us, Peter, because the technicians that work with me, despite my best efforts, because we are an urgent/emergent specialty, are going to spend hours outside of their original expectation. It is not. Last night, you had emailed me prior to the podcast, and I didn't email you back because we were at work until 8:30 doing a back that we didn't anticipate doing. And so I think retention can be even harder for us in that regard because people have families and lives. Outside of myself, I'd first target the hospital I work at. Again, that's the constant question. In fact, we, as a leadership group, we said, what's the most pressing problem? And this was it. How do we continue staff retention, not just with technicians, but with the front of the house staff? And there's the financial things, there's the treats, and there's the parties, and there's the recognition in that regard. But really, it's just making them feel like they're what their worth is, not making them feel, showing them what their value is. And that's being a larger part of the team. If you're a receptionist sitting in the front and you get an angry client that's barking at you about their dog that's not walking, do you get to be part of that discharge when the dog is? Do you get to show that you were a part of that process? I think that's a huge part of it. And then I think another thing that I've always been challenged with is, where's the line of hierarchical division in that I am friends with my technicians. We go for drinks after work. We commiserate about not only work things, but about personal things. They know me very well and I know them very well. And I've been counseled sometimes that that's not the way to do it. And I'm sure there is a line somewhere, but ultimately, these are my colleagues and my friends, and you like working with your friends. I like working with my friends.
Yeah, we have to remember that it's not just the money that they stay for. It's that respect, recognition, and responsibility. It's the growth as a person. It's the perception of a career and not just a job. And that really depends upon the culture within your practice. And it sounds like you've got a very positive culture that is supportive of your team in a very high stress environment from that standpoint.
Yeah, I think ambition to grow. When I initially thought what growth was me being better at, getting more degrees, getting more accolades. For a lot of my team, growth is getting that catheter in more effectively, running the MRI in a way that the resolution was improved. It doesn't have to be necessarily career advancement as it is personal fulfillment.
So let's look at the future of veterinary specialty practice, and the last 5 or 6 years have seen a growth in urgent care facilities. They've seen a greater utilization of emergency facilities, but we've also seen tremendous disruption, as I've heard anywhere up to 75% of the specialty practices have been purchased by national corporations. Then concurrently, I've also seen a large number of private practices developing and being spun off, for lack of a better way to put it, from associates who had been in that corporate buyout. I've also seen some hybrid practices, especially with surgeons and internal medicine, more general internal medicine people working concurrently at a general practice. And then, of course, you mentioned earlier, universities. And so we've got these kind of four, and there may be others down the road. We'll talk about that. But what's the road forward? What's going to happen with specialty practice and this corporate absorption? Will we start to see more privates and hybrids? And you mentioned earlier, and it may even before we got started, what's happening with the universities, because it's really hard for them to find specialists, and the hallways in some university hospitals are pretty empty of boarded specialists. So that was a long-winded question to ask, what's the road forward?
How long's this podcast? I got some things to say.
The floor is yours. We can edit it down, or
no, I think it's a big topic, and something that in the meetings that we have annually among specialists. It's not only happening, these conversations aren't only happening in the business meetings, but they're happening over a beer over and over and over again. So, I mean, a couple thoughts. Expectations of younger specialists are different than the senior ones. And I don't want to be the generationalist that says I walked uphill in the snow with bare feet and newspapers tied around them. But the expectations are different. And I think that between the post-pandemic era, when there was such a need, and the corporate pockets that are now lining a lot of these practices, the offerings are different than they were when a lot of us got started. And so the expectations are different with regard to pay scales and time. And a lot of people would suggest that the millennial generation is different than the Gen X's as far as work-life balance and expectations of how much we contribute. So I think that there is a difference in that regard. And I think that what that leads to is specialists working less hours, which means less volume to accept those cases to a certain degree. I think that there's also this really interesting question of what's going on with the large multidisciplinary specialty clinics versus the individual specialty clinics. The large individually multidisciplinary specialty clinics didn't exist 20 years ago. They were academic hospitals, teaching hospitals, and then specialists, once they were being produced in mass, were then going there. A lot of our listeners, our young listeners, might be surprised to hear that when you learned neurology or surgery or even internal medicine, you didn't learn it from a specialist. You learned it from a veterinarian that was really interested in those things, and then specialty medicine later emerged. I work right now at a large specialty clinic that is not corporate, and I have not worked for a consolidator, so I have limited experience with that. But there's advantages to that big multidisciplinary clinic. You get this opportunity for collaboration between specialties. You can tackle complex multi-system disorders. That said, those big multidisciplinary clinics are encumbered with the challenges of big administration, big overhead. The reception has to accommodate the needs of an oncologist and a surgeon and a cardiologist all at the same time. And so despite the fact that you get this real big Mayo Clinic feel, it has its deficiencies as well. And that's why I think more recently we're seeing the smaller single specialty clinics like an MD Anderson kind of emerge, and that they can be more nimble and provide more directed treatment, maybe more specialized through specialized equipment, maybe more luxury individualized care. Maybe it's cheaper because you can be more nimble in that regard, and they can serve underserved areas. In other words, big specialty disciplinary clinics need to be in big urban areas to get the volume to frankly make revenue work. Smaller clinics may have the opportunity to be in, podunk town in the middle of nowhere, because that's where that specialist wants to live. So there's the value in that. I'm excited about the latter. I don't know if you've ever read Atul Gawande's books. He wrote a book called Complications, one of my favorite books. I recommend every listener out there goes and gets this book right away. When he wrote this book, he was a young surgical resident. The premise of the book is that we take a lot of risks and we put our patients in danger for our own training. But one of my favorite chapters was about hernia repair. What it suggested is that with inguinal hernia repair, there is an 18% complication rate at all hospitals except for one, where it's 2%. And if you're wondering what's different about that hospital, that's the only surgery they do there is inguinal hernia repair. I think a lot of us are taught, just like we should be the veterinarians that know how to do everything that our technicians do. We're the veterinarians that are taught the more you know how to do, the better you're going to be at it. The more surgeries you can do, the more you can handle any bad situation. But the data would show us that the more specialized we are, the more we do less, the more we are a master of one as opposed to a jack of all trades, the better job we do. And so I think that may speak to the value of smaller subspecialized clinics, or at least departments within larger clinics, than this idea that the general surgeon should be doing a TPLO and then a PDA repair and then a PU all at the same time. So I think that's kind of an exciting thing to think about. And you had asked Peter about academic versus private practice. I think this is one of the scariest things, because despite of a lot of the fact that a lot of us are in private practice, and I do have an adjunct position at Mizzou and at North Carolina State, we revere those halls of academia. They're what make us better, and in their absence, the future is a little scary. But I think academic posts are not grabbing specialists because they pay significantly less. They have to. They don't have the revenue to pay more. And they're in land grant locations often. So if you had the choice between living in a rural environment or the city 2 hours down the street, you probably, or for a lot of us, would choose the latter, especially given that we're a small animal and that's where the volume of cases is going to be. So many of the programs are short-staffed, and the problem with that gets worse, because now if you have fewer academicians, those academicians who may have gone into the position because they want to teach or they want to do research are stuck on the clinic floor. So not only do you have less academicians, but you have those academicians that don't get to do the things that advance the field. One of the things I'm most proud of is that we were the first group to establish a private practice academic hybrid residency program. When you go into residency, just like anything else, you have to choose, do I want to go in academia? Do I want to go to private practice? You get the benefits and detriments of both, and that's a whole different podcast. But if you could pick a program where you got to do both, and not one where it's somewhat of this and somewhat of that, but it's a cohesive group of mentors that give you a variety of different experiences, that may be appealing. And I think for specialists, if we are going to mirror the human field, that's where we need to go as well, where specialists can get the opportunities of private practice, not only financially, but volume and equipment wise, that they also get to scratch that teaching itch, get to be a part of education, and more importantly, to be a part of advancing the field. So I think that might be a really cool place where we're going.
Yeah, first of all, there's so many things I want to touch on that you just mentioned, but Atul Gawande, as a business person, I suggest everybody read Checklist Manifesto. As a clinician,
Absolutely.
Complications in some of his other books are outstanding from that standpoint. And the concept of specialization in human healthcare has gotten almost to an extreme where people will only deal with your left pinky. But of course, you will get the best left pinky surgeon in the world. And we've seen it in ophthalmology, especially with the clinicians that are doing LASIK procedures, because that's all they do. And in an urban suburban area, there's almost a need to be focused, because being a jack of all trades, you end up being a master of none. On the other hand, veterinary medicine is, at least the companion animal side, is only about 60 or 70 years old. And so we are still not that far off from the good old days of riding in the dales of the UK and getting paid in bacon and eggs. So it's a slow transition, but I think, and I jest that if I were opening a veterinary hospital, it would be hunting dog puppies only till they're 6 months old, and then they can go someplace else for all the pain in their future. I just want to take care of them when they're puppies. Well, we have that in human healthcare. It's called a pediatrician. What we really haven't developed in veterinary medicine is gerontologist. So we take everything from womb to tomb, and it makes it even more complicated, even more stressful from a generalist standpoint. And I could even see a neurologist that there would be a brain neurologist and a spinal neurologist, and infectious disease and all sorts of different things. So there's ways that we can do this, and hopefully.
And I think that's happening, Peter. Like, I do think it happens. So in our field, I would be more of a spine guy than a brain guy. It's just that's what I'm kind of known for in my circle. But I don't think any hospital is going to be happy if I said, yeah, I'm only seeing the spine cases, unless they were able to find another specialist that was able to see only the brain cases. So I think the demand on the hospitals, especially given the volume that they have, precludes us from specializing. But I am excited, especially on social media, to see these entrepreneurial young generalist primary care veterinarians taking up things like senior patient care, end of life care. I mean, I think that's an exciting thing that is happening for the better, I hope.
And one other thought regarding this hybrid that you've got with the university, if specialists at the university could be making what they could make in a private practice, then we would probably find the university a more attractive setting. But part of the problem is the land grant universities and state mandated budgets and everything else make it a little bit harder to pay boarded clinicians to stay. And I think in human healthcare, and I may be wrong on the details here, but many of the people who work in the hospitals and are also part of the teaching faculty are allowed to make an ancillary income and are paid as a specialist, not as an academician. And we have to figure out how to pay specialists as specialists and concurrently as academicians if we want to get them to, in my opinion, if we want them to get them to be part of the teaching hospitals of a veterinary university.
When I had the fortune of working at the university for 4 years before going to private practice, and I was frustrated to know that my income was somewhere between a third to even a quarter of my colleagues down the road. When I voiced this frustration, they said, well, let's look at your revenue and see if what that would be in the private practice. And in the academic setting, because of multiple departments and students and the expectation of teaching, I was getting paid what I deserved to be paid, at least from a revenue standpoint. Now, specialists are, I think, a veterinary neurosurgeon is not like the human neurosurgeon where you can't find them because they're walking around the golf course. These are, my colleagues are not greedy. I think that if there was a lesser disparity and you could make similar money, even half of what you could make in private practice, I think you wouldn't be able to find an open spot in academia because it is so attractive to be able to teach the youth of our profession and to be a part of making a difference in the future of the way we practice. It's just the disparity is too great. And I think if we can narrow that gap, perhaps through something like a hybrid, that's how we get there.
Yeah, well, as somebody who teaches at a university part-time, recognizing my rate is about 25% of what I normally bill, I'm with you.
Yeah.
But I'm doing it to help set the generation, the future generation in the right direction. So I'm with you.
Yeah.
One of the issues, the global issues impacting the veterinary profession, and I think it's getting worse before it's getting better, is the cost of care. And it's not, it's in general practice, it's in specialty practice, to the point where I think a lot of the data that we're seeing, at least in companion animal practice, indicates decreasing transactions, but increasing revenue, which means we're making more on the backs of the individuals who are paying. So cost of care is headline discussion points. It leads to relationship issues. It leads to trust issues. It's got to be very frustrating at the front desk. It's frustrating in the exam room. And of course, when we look at referral from a general practice to the next tier, pet owners expect the cost of care to be comparably escalated from that standpoint. So we're now getting to a point where a back that you cut could be an issue. And it's expensive to run a veterinary hospital. And there's a lot of reasons for that we don't have time to get into. But it's even more expensive to run a veterinary hospital that has an MRI, a CT, and all of the neurosurgery, magnifying cameras and everything else that you use. Is there an affordable specialist model on the horizon so that more people can have access to the techniques and resources of somebody like yourself.
Yeah. And again, I feel compelled to say that the EBITDA, these revenue margins that specialists are making are likely quite similar to their primary care counterparts. It's not as if specialists are saying, I'm better, I should make more. I think that when it comes to luxury care, and like you spoke to, the technology and the administrative components have made this become cost limiting for a lot of our clients. And I think that our clients, despite the fact that there's clients that lose out from that, I think there's other clients that have expectations of care that's commensurate with what they would get in a human hospital themselves. So I think it's a bit of a buzzword right now, but we have to embrace the spectrum of care. At its basic level, embracing the spectrum of care, we know is empowering the primary care veterinarian to do more. I lecture with Natalie Marks on this a lot. How do we create a team and empower the general veterinary population to do spinal taps, to do advanced diagnostics that they were otherwise ill prepared to do coming out of veterinary school? How do we help them make better decisions given the handcuffs that they may have on them, whether it's from the client side or from their own capabilities / technology side? So I think that's the most basic type of spectrum of care. And I'm sure you've had other people on here that have spoken about that. I think that the place where you're speaking to is where does it get less expensive comes into spectrum and care with regard to what the specialist offers. In other words, where does the line get drawn between providing optimal care and suboptimal care? In other words, a back dog comes in. I can do a myelogram on that dog. That would be less expensive. The challenges with that is that there's dangers of a myelogram. It gives me less diagnostic capabilities. If I do surgery off of a myelogram and it goes badly, that puts me in danger of legal ramifications when I had the MRI. And the other hard part from a revenue standpoint or a financial standpoint is how do I justify having the MRI, which is extremely expensive to maintain, for the 60% of my clients that want it, when now 40% of the ones that would have otherwise had to have paid for it, not paying for it any longer, And so it becomes harder for the people that want that higher level of care and more expensive if we start providing that spectrum of care within what we do. So that's a long way of saying I'm not really sure how we handle that from an affordability standpoint. I think that as technology improves, there's two ways it goes. One is that things get more expensive and things get less expensive. A 1.5 Tesla MRI, you can get one now for $1 million or you can get one for $300,000. And I think you're going to see a disparity in, or maybe a stratification in different hospitals. One that says we offer less expensive care with lesser technologies and we offer more expensive care with higher end technologies. Otherwise, splitting the baby there becomes more difficult than it sounds. Does that make sense the way I explained
Well,
it?
it does, and it makes it a challenge for the primary care clinician who's sending a case to you, thinking, because you don't know as a primary care clinician about what all the costs are, what all the overheads are, that if it's a back, oh, Dr. W is going to do an MRI and he'll find out whether there is a surgical intervention that will be beneficial. If not, he'll talk to you about alternatives. So you start to have a need for even more collaboration between your primary care clinicians and your specialists to understand the spectrum of care discussion. Because the spectrum, because as a primary care clinician, the minute I say I think you should see a specialist, the client probably starts to hit a panic mode. It'd be interesting to put an EKG on your clients in the exam room and watch, or maybe a blood pressure monitor, and watch what happens when you go from, oh, good little puppy, oh, grade 6 heart murmur,
Mm-hmm.
or
100%.
yeah.
I just wanted to add one more thing. The spectrum of care, you'd think that if you offer lesser care, It's an easier conversation, less time. This is what we're going to do, move on, as opposed to more intricate on the other end of spectrum of care where you're doing advanced technologies and invasive procedures that's bigger and more involved. The middle grounds can actually be the most challenging. If I do an MRI and a surgery on a dog that has a back problem, it's a quick conversation because I know exactly how it's going to go. I'm using optimal technology and my chances of complications are lower. If I'm doing a lesser diagnostic or a less preferable surgery, the chances of things not going the way I expect or provide expectations for my clients go up. And then the expense then there's the challenge of those conversations, the likelihood of issues. And so sometimes trying to help the clients financially actually causes a lot more, for lack of a better word, grief. And I think that's part of the hesitation in finding that middle ground sometimes.
And correct me if I'm wrong, it wouldn't be the first time, that we don't have enough outcome studies from spectrum of care standpoint. In other words, we have to do a better job of sharing these cases. Let's use a back as an example because we started with that have an MRI, go to surgery, and have good outcomes, intermediate outcomes, or bad outcomes. Same case goes to a myelogram, goes to surgery, yada, yada, yada. So if you could tell a client that based upon my experiences and the experiences of other neurosurgeons around the country, this has a 50% chance of success versus the next has I don't think we have enough of those studies in veterinary medicine. Correct me if I'm wrong.
No, that's right. And when it comes to back dogs, that's an area of constant research with regard to outcomes. But the bias inherent in those meta-analysis is so high because the cohort of dogs that gets medical management versus surgical management is not by a blinded placebo-controlled study. It's by the capabilities in that area and the fact that it was reported by one veterinarian as opposed to another that does surgery. So there's just such significant bias from a when was that study created versus current technology, and from a who's writing that paper, that it becomes apples to oranges very quickly.
As we're having this conversation, I'm thinking of one of our mutual friends, Adam Chrisman, and I'm thinking he's got to have you as number one on his speed dial since he's now got 4 doxies, and he's written a book about doxies and backs. And by the way, did you contribute to that?
I did not. The book came out before our friendship, but I have counseled him on when his sausage dogs start having some weakness in the back legs. So yeah, but I know he has a very good local neurosurgeon. So.
Oh my gosh. So good stuff. Good stuff. Well, let's just take a couple of minutes and one more. Do you have any concerns about the future of boarded specialists, or are you still pretty optimistic that we'll be able to write, not that the ship is wronged, but just to redirect the way things are going to look from a future regarding boarded specialists?
Yeah, I think that it is complicated from the standpoint that just like in the general veterinary field, in the specialty field, the breadth of knowledge is becoming too great for any one specialist to be special at. So what has to come from that? Well, one thing that could come from that is longer training. That's hard, or more directed training early. That's challenging. The other is super specialization, which we spoke to the ills of before. I think that another thing that needs to be pushed in the specialty world is how we communicate. I know from going to fetch conferences and all these other wonderful conferences that communication and interaction is a huge focus of the programs. It's barely present in the specialists programs. And so I think that's really a travesty, especially considering that we have 2 clients as specialists, as opposed to the general practitioner where we have 1. Our clients are our clients, but our primary care veterinarians are just as much buying into this process as well. And if so many of my colleagues have not received training on how to speak to their colleagues outside of their own hospital. And so I think that that's something that that concerns me. And I think that there's a lot of opportunity there to make that better. And then I think last is the expectations of income concerns me for specialists. The expectations of income continue to go higher to high and higher, despite less and less time on the clinic floor. And that's going to lead to some of the things we just talked about. So
there's a lot of different issues impacting the veterinary profession globally, and I would normally spend some time, but I really have enjoyed the conversation we've had. So I want to kind of wrap it up with just one question about, I don't want to use the term controversial, but I will, telemedicine, telehealth. And I have always appreciated the fact that when I was in practice, I could pick up the phone and I could call Steve Hansen, who was the neurologist in my neck of the woods,
sure.
or Wayne Berry, and talk to them about my case. Wayne cut my own dog. And that was kind of a business to business telemedicine. But we've started to expand that into business to client. But there's also, and in most cases, if I would call them, there was no charge for it. So do you see some changes in some of the business relationships that might occur in terms of telemedicine, where you might be charging a primary care clinician, or especially if you brought a primary care clinician and a client on the phone? Or do you have any input or thoughts on where telemedicine can fit in veterinary medicine going forward?
Yeah, I think it's to some degree specialty dependent. There are some specialties that really lend themselves to telemedicine, both with the generalist and with the client directly. Things that come to mind are oncology, because they're not procedural heavy specialties. And what their greatest attribute is their big brains, and so they can really provide a spectrum of care and procedural recommendations within the general practice way more easily than, say, I could, because I'm very limited by the technology that surrounds me. And while I could help Peter, we could have a conversation about a case, and I could tell you, yep, this is where its problem is. This is probably what's wrong with it. I probably need to see it, or you don't need to send it. So I do find that heavy procedural specialties, more often than not, it's a question of referral or not. But I think that there are other opportunities within specialties to actually make more helpful telehealth recommendations. With regard to charging or not charging, and I know that there are all these pay-for-play specialists that will provide consultations. I don't understand it, and maybe it's a volume question, but my local referring veterinarians are my primary lifeblood. They're my clients, they're my friends. We develop relationships over cases. To not provide them with every piece of value that I can, regardless of payment, why are you biting the hand that feeds you? I don't understand it. I mean, a specialist is nothing without their referral base. So how could you penalize them for asking for help? I feel kind of strongly about it. I don't know if I'm in the mainstream, but I would never think to ask a referring veterinarian for money for help. And for my part, my personal story, to a certain degree, is I left academia because I wanted to try my hand at private practice. COVID came around. Instagram became something I'm familiar with. And then I would wake up on Sunday morning, say, hey guys, meet me. I'm going to go look at some cases. As I soak them in the morning, we could talk about them. And before you knew it, I had 600 people from all over the country seeing cases with me. And it opened up a whole new world for me with communicating with veterinarians. Personally, I get so much enrichment from helping veterinarians tackle complicated neurologic cases that I think telemedicine is huge, but to make it a financial barrier doesn't make sense to me. Before I get off my soapbox here, Peter, I did want to say one more thing about your question with regard to specialists that I was triggered about as I was talking. I do worry about what the distributive model of schools does for specialists. If we're having trouble getting advanced care veterinarians in, or people into advanced care, what veterinary student that has never been exposed to a specialist is going to want to be a specialist. I'm very worried about what that means. And I'm curious to see what the distributive model actually looks like with regard to face time and exposure to specialists in their clinical years.
I can speak to Western, which has the benefit of being in the Los Angeles area and the ability to send to a number of specialty referral practices. And about a third of the class that I teach has expressed an interest of going into a post-education. About a third want to be owners and a third want to be associates, post-education, including public health. So it probably just depends upon the relationship that they develop. But when I was in vet school, and I'm sure as you chose which rotations, internal medicine, surgery, equine, whatever. And if you don't choose to do neuro, it all then depends upon what you got didactically. And you're not going to maybe see the back cases physically, except what's in the classroom. And so I look forward to seeing how this continues to play out. It's still an incomplete book, in my opinion, as to how this all is playing out on the distributive model.
Yeah. And to your point, it's not just the cases that you get exposure to, it's the person. I remember doing dentistry at Penn, and I thought to myself, what am I doing on this rotation? And we had the most engaging instructors, John Lewis and a couple others, and I wanted to be a dentist. So a lot of times it's the exposure to an inspiring person that can change your life, and I hope that is something that gets taken into account.
Absolutely. So I have two more things.
Okay.
When I shared some thoughts with you, I put a line item that says alternate universe. And you probably saw that and said, oh God, where's he going with this? Here's where I'm going. And I'll ask the question slowly so you can try to formulate an answer. In March of 2020, the veterinary world, the world in general, was turned over by a 100-nanometer virus. And everything changed. Every freaking thing changed. Here we are, January of 2024, when we're recording this, almost 4 years later. What do you think the world would look like in 2024 if we never had a pandemic?
I have to think about that for a minute. I mean, because when I think about the pandemic and what it did for us, obviously you had a plethora or a dramatic increase in the volume of animals that people owned. You had, which still is in its infancy, if you think about it. We're not going to be presented with those cases of sick animals from those pandemic puppies for another 6 to 8 years. So the ramifications of it are still unfolding. You had people that were spending more times with their dog, and I think the human-animal bond became stronger because of the time and isolation at home. And you had the Great Resignation, where we lost probably 30%, maybe you know better metrics than me, of our infrastructure, because if you had to work late hours for crappy pay, or you could work down the street at Panera for more, what would you choose, right? I'm trying to remember better where we were heading. And I think as a specialist, our big concerns were we're making too many specialists, and I don't know if we have the volume to support it in the long term. We're going to get saturated, and people are going to have to move to underserved areas. And despite the fact that you made $20,000 a year for 4 years, while your colleagues then general practice were making 90 or 100, you're going to have to settle for maybe even being a generalist, despite your advanced training. So I wonder if we would be having this conversation at all. I think that specialty medicine was heading for saturation very, very quickly, with a lack of interest in advancing the support staff field. I don't think the mid-level practitioner was even a conversation at that time. So I think the landscape would have looked very different. And I think that the challenge would remain, how many specialists do we need? And how do we limit the programs to make sure that we don't oversaturate ourselves? I think it would have been very different.
Isn't it an interesting question to think about, though?
Yeah, it really is. It changed everything.
Right. So
Yeah.
what's next for Fred? Besides what's next after you get off the phone after the call with me, but what's next for Fred?
Um, a couple things, so I have my 3D printing company. I make customized individual tools for different veterinarians. I'm excited to be a part of that. I am really excited to continue engage this idea of spectrum of care. And I have a lot of collaborative efforts with colleagues. Peter, if you ever want to give a talk together, let me know. We'll do it. And I'm excited to explore this idea of what small non-multidisciplinary clinics can do, because I think it's an exciting time to get into specialty medicine, and I think it's an exciting time to consider what we can do to help the population, especially in underserved areas.
This was so much fun. I mean, I hate to wrap it up. We'll have to do it again, maybe in front of a live audience sometime where you can show everybody how smart you are and I can try not to be dumb.
Please.
But, if I'm so happy that our paths have crossed, and I have to thank Adam and Natalie Marks for the introductions and this conversation, because I learned a lot. I hopefully pulled some things out of you that you wanted to share, and I look forward to the opportunities. I'll be seeing you down the road sometime. Great conversation, great chat, all sorts of different things that we can go off on tangents, and maybe we'll do this again sometime in the not so distant future.
Any day, let me know. I really enjoyed it, Peter. I think your podcast is extremely thought-provoking. I'm gonna definitely dwell on some of my answers and think, well, I wonder what I could have done different. So we'll have to just circle back and do it again.
So thank you so much, Fred, for joining us again and talking to us about changing the paradigm for veterinary specialists. We appreciate it very much. I also want to take a moment to thank our listeners. We appreciate each and every one of you. We can't do what we do without you. If you like our podcast, kindly share it with your colleagues and friends on social media. Also, please don't forget to leave us a review on your favorite podcast platform. Your reviews will help other doctors and practice owners and associates and students and the like find us. Until next time, keep striving for excellence and making a positive impact in the lives of your patients and your pets. Wishing you all an amazing week ahead. And thanks to all of you for listening in. Much appreciated.